Welcome, everyone, to the fourth installment of the 2020 HIMSS ePatient Summit, Changing the Future of Diabetes Management. And please get comfortable, get involved by using the chat and the question features, and be sure to respond to some of our polls. We have a couple of them. Again, thank you really for joining. And I really wanted to first thank all the healthcare workers out there on the front lines, as well as those working and for all that you do, especially for those that are in need and those that are needing care. I am Vu Van. I will be your moderator for today and for today's session. I'm the Regional VP for Health Systems with Livongo, and I work with health systems executives and health plans to provide Livongo solutions for healthcare employees. And at Livongo, our mission is to empower people living with chronic conditions to live better and healthier lives. And we meet the member where they're at, and that's where the name Livongo comes from, living on the go. So just for those who are wondering, Livongo started with diabetes management, and we have expanded into other chronic condition solutions such as hypertension, DPP, weight management, and behavior health. And if you're interested in learning more, please do connect with me. There is a link on the bottom. If you want to click on that afterwards, it'll take you to our Livongo page. And thank you, Livongo, for sponsoring the session. Now I'd like to introduce you to the panelists for today's session, and then I'll start asking some questions where the panelists will provide their insights. So Dr. Nicolas Cuttriss is a practicing pediatric endocrinologist. He's a public health professional and a social entrepreneur. He is committed to solving complex, large-scale social health programs or problems. And in particular, Dr. Cuttriss has a unique dedication to improving the quality of life of people living with diabetes and chronic pediatric endocrine conditions, and to training the next generation of leaders and global citizens. Dr. Cuttriss's leadership in the conceptual design and implementation of grassroots health outreach and training programs have gained international attention, with a leadership role in the UDA, which is the American Youth Understanding Diabetes Abroad, as well as he developed an innovative peer-based service learning delivery model in diabetes for training, placing and supervising students, volunteers abroad. Dr. Cuttriss served as the first pediatric endocrinologist for the University of New Mexico's Project ECHO Institute, which is the Tele-Echo Clinic. And now he joined Stanford University to further evaluate and scale the model to include type 1 diabetes. And he now serves as a director for the Project ECHO Clinic at Stanford University. Next, we have Dr. Gangupantula. I'm going to refer to her as Dr. G moving forward because I don't want to be tongue-tied with that. But she pursued her passion for diabetes and has received fellowship certification in diabetes from East Carolina University in North Carolina. She specializes in intensive insulin treatment, including insulin pump management, oral hypoglycemic agent management, non-insulin injectable treatment, and obesity management at the Valley Diabetes and Obesity in Modesto. Her goal is to set that up as a center of excellence and available as a resource for all the members of the community with the best of care, education, and social support. She partners with the local health system and devices and pharmaceutical companies to enable patient assistance programs for insulin and CGMs. She is a key participant in that Stanford Project ECHO for Diabetes as well, intervention program and collaboration to deliver increased access to diabetes care for the underserved residents of Stanislaus and San Joaquin counties. Great to have her. And last panelist, last but not least, Anmol Madan. He is Livongo's chief data scientist, where he is responsible for machine learning and data science across all of Livongo's products and services. He helped people be the best version of themselves. And Anmol previously co-founded Ginger.io, I read in your apartment, and an AI-driven behavioral health system that provides access to 24/7 coaching, therapy, and psychiatry. And he served as the CEO for 7 years there. He received his PhD in machine learning applied to human behavior from the MIT Media Lab, and has authored 20+ scientific publications and over a dozen patents related to machine learning in healthcare. He has been recognized as one of the 100 most creative people and as a World Economic Forum technology pioneer. So great to have the panelists. What I'm going to do is I'm going to ask a quick fun questions for each of the panelists to get started, and then we're going to go into the more serious questions. So the first question is, I'll start off with you, Dr. Cuttriss. What is your favorite song on your playlist? If you would share that with the group.
My favorite song, is Burning Down the House.
Burning Down the House. Nice. And is there anything positive that came out of this COVID-19 pandemic experience that changed you moving forward?
Well, it's always challenging to figure out how to work and homeschool in the same household. Just having that opportunity to be around the kids more and seeing them and making new recipes together. It's a really nice thing to be able to do.
Recipes, nice. Talk about recipes. Let's go to you, Anmol. What's your favorite song, and what has changed since the COVID-19 for you?
Yeah, so I'm a podcast person more than a music person. So probably a lot of podcasts, either something like The Daily or a bunch of other NPR shows probably on my podcast.
With Michael Barbaro?
Michael Barbaro, yes. Yes, that's a familiar name. In terms of what's changed, I think it's fascinating. I think I've never been closer to a lot of my extended family, and we actually are all talking very regularly. We talk to my dad every day, which is unheard of. And even though he's not in the same city as I am, and we're recreating a lot of the recipes actually from my grandmother, who passed away a long time ago. But we had these sort of family ideas, and so all the cousins are kind of experimenting and recreating, and we all live here, and she was in India. But so it's been going back to some of the more basic roots that we all kind of relate to in this time where everybody's quarantined and stuck at home.
Excellent. And you, Dr. G?
Well, I do yoga and chanting, and during this COVID pandemic, I have actually a favorite song in Hindi, which translates saying, "Dear friend, hang in there. Just hang in there. There is definitely going to be this difficult time will pass, and there will be light that we see soon." So I like that song to keep me going. And the good thing that has come out of this is I'm able to spend more time with my kids. They are at home, even though they are mostly, doing a little bit of homework and schoolwork, but most of the time they are playing games and stuff. But I see them in the kitchen more, trying different recipes. They are teenagers, so they are always hungry and they are trying recipes. And the advantage is I get to eat all that.
Excellent. Well, we're all teenagers once, and we're all hungry when we're teenagers because we're growing, right? So Thank you. So since I have you talking, and everyone, thanks for sharing, I'm going to ask the first serious question. Dr. G, if you can kick us off. We hear about people with diabetes who have had to choose between buying food or insulin. Even if you have insurance, either the drug is not covered or has a significant cost. It reflects one of the health system's flaws. How does the panel see this issue worsening the condition we're in? Dr. G, if you can kick us off.
That is actually a very valid concern during these times. I have patients who will underuse insulin, or they'll skip picking up a prescription because they can't afford the cost. Sometimes I have patients who will say that they have stopped using insulin because it's too costly for them. And looking at some research which shows that insulin cost has tripled, I think from 2002 until 2013, and over the past few years, sometime in 2016, it was found that it was continuing to double. So there are a lot of patients doing rationing. They try to save the money from not buying their insulin or paying for their insulin, and they're looking and going out to the market to find foods. But they do also feel that the healthy foods are more expensive, so they end up buying what they can afford. And then what I try to do is I try to help them by getting samples and giving it to them. Whenever they need, they have the access to call my office, and I do what I can. So it is a valid concern. As far as your question about how it's going to be worse, hopefully it will not get worse. Rather, the Novo Nordisk company actually has said that they will give 3 months supply of free insulin for patients who will proof of losing their job. And I think Sanofi or Lilly, one of these companies, I'm not really sure which one, they have said they'll put a cap of $35 on their insulin copay. So hopefully this should help.
Yeah, no, that's excellent. I did read that recently about Novo Nordisk, so that's great that they provide that. Dr. Cuttriss, anything to add on that about the issue worsening, the conditioning that we're in, especially in the pediatric market?
Yeah, so I mean, I think it's commendable of the pharmaceuticals for coming out with these copay assistance programs, and it's needed, and hopefully that trend continues. But even $35 is a lot for lots of families right now, where that could go to their food, and so I think we're going to hear more about this in the months to come. And when I try to address food insecurity with patients in the pediatric population, it's not something that they bring up. It's really something that I have to probe at, and families are not proud to speak about it and kind of ask for support up front. And we need to come together as a community with your local community and try to get plugged into the right sources depending on where you're living. Because at Stanford, we see people from all around the state, and what might be a food resource here in Palo Alto is going to be different, up in Humboldt County, for example.
Yeah, excellent. Yeah, so I'm going to go to the next question. That's something to think about, and we're seeing it in real time, right? How people are addressing an organization. So it's great to see that. I'm going to move to the next one, and Dr. Cuttriss, if you can continue with this question. What are the biggest challenges for people with diabetes during the COVID-19 pandemic? And then I'll go to you, Anmol, to follow up. Dr. Cuttriss?
Yeah, I mean, I think first and foremost, it's the same as anyone without diabetes, right? And then, so they're going through the same thing. I don't have diabetes, but they're going through the same thing that we all who don't have diabetes go through. And then add on the job of having diabetes that they didn't sign up for. That's 24 hours a day, 7 days a week, not getting paid to do the job, and no vacation from the job. And so just, it's overwhelming. And then based on everyone's individual circumstances of kind of how vulnerable they are, then you have those additional burdens on top.
Yeah.
So almost same question. Yeah, biggest challenges for people with diabetes during this pandemic.
Yeah, no, that's a good question. And so I think one of the things that we're seeing, and again, I come from a data and technology background, and so I'm the wrong kind of doctor in some ways. But one of the things that we're seeing clearly is, in some of the data we've seen, is 78% of people who've made it to the ICU have at least one chronic condition, right? So the fact that people having chronic conditions, and diabetes being a predominant one, but I'm sure heart disease and other conditions as well, obviously is playing a huge role in the impact COVID is having in our populations, in our society. And so one of the areas that we've been very fortunate to be at the center of is this idea of remote monitoring and giving people support and figuring out how we can help them in this situation. In many ways, the underlying technologies, I think, have existed for quite a while now. Telemedicine, remote monitoring, I think these concepts in themselves are not new. But I think what the recent challenges have highlighted is the role that these technologies can play in helping our patient populations and member populations across our society. And so particularly for people living with one or more chronic conditions, and diabetes being an example, making sure that we're really understanding, who is at risk, how can we support them using these data, using these sensors out in the real world, as these surveillance efforts increase and improve across our society, and it may take many forms. There's a lot of ideas being proposed. Contact tracing, location tracing, antibody testing. As those surveillance data improve, how do we then integrate them and understand who is at risk and support them and kind of build these remote monitoring systems that can really help people? So I think that's our, clearly a lot of risk here for those populations, and so that's the way that we're going around and thinking about the role that technology can play here.
Yeah, no, thank you. And then I'm going to go with you, Dr. G, but a couple of comments that I'm seeing in the chat, some great ones. Pertaining to this question is a big challenge is people with diabetes cannot go for their monthly, quarterly routine checkups. And I think you addressed that, Anmol. We have folks, Karen from Denver at the Barbara Davis Center, is trying to see kids in person as much as possible, but is also doing telehealth appointments. So trying the different technology to maintain that level of care. So Dr. G, same question for you, because you're seeing the patient in your clinic. So what have been some of the biggest challenges during this pandemic for them?
The same thing that it was mentioned before. The regular follow-ups we are not able to do, but I'm trying with telehealth, and that's a very good tool to help these patients. So we prepare them for the telehealth visit and have their blood sugar tests and logs ready for us to review. Then I also help patients to understand that checking their blood sugars more often, more frequently will help them through this COVID pandemic to make sure that they prevent complications of diabetes or hyperglycemia, to help them keep them out of the ER or, prevent DKA. Adequate, I tell them to drink sufficient water, keep themselves adequately hydrated. So stuff like that helps them to stay healthy.
Yep. Excellent. Let me ask this other question that's in the chat right now that bubbled up. Looking at 3 to 5 years into the future, what will be the different for diabetes management for the type 2 adult patient?
If we are looking at these devices, that is what is going to actually help these adult type 2 diabetes management. Having a CGM actually helps patients to have this data, real-time data in their hand to be able to change their lifestyle, or at least this data will, from the data, they actually see how their food or activity impacts or affects their blood glucose levels. And that helps them to make some behavioral changes and lifestyle changes. And I think that is the biggest thing in the coming years for type 2 diabetes management.
Yep. Dr. Cuttriss or Anmol?
Yeah, I think there's, lots of behavioral health support systems out there like Livongo, but now we have the opportunity to really incorporate the medical management component, which is just one piece. That's not all, but I think that's one piece that's been left out in terms of being able to do remote monitoring. And type 2 is not just in the adult community, it's also in pediatrics. And if I have a patient who's pediatric type 2 diabetes and they're on insulin, insurance doesn't approve CGMs right now. So I can't get a patient with type 2 diabetes on a CGM unless I'm twisting arms. And so hopefully within 3 years, if not sooner, whether you're on insulin, no matter what type of insulin or what type of form of diabetes you have, we can democratize this knowledge and let these patients see their data, understand it, and make changes.
Yeah. So, well, if I can just sort of bring a couple of those comments together, I think the 3 to 5 years is a great question, because what has happened is in the last 6 weeks, we've catalyzed a lot of things in our society that have accelerated what would have typically happened in 3 to 5 years. And so I want to pick up and sort of go deeper into a couple of trends that we're seeing again, and as one data point. So we heard about the concept of sort of telemedicine and remote monitoring sort of now becoming mainstream. So the idea that we can deliver healthcare, deliver services, and deliver sort of medical support on a digital platform, and then augment it over video quite often, then augment it with data and sensors that people are handed out, I think is becoming very mainstream. And so just to use Livongo as an example here, the idea that we can do blood glucose checks, we can provide strips, we can provide coaching support, we can provide telemedicine support, and all of that around one bundle is sort of much more mainstream today than even it was sort of 6 weeks ago. Like that sort of mindset has shifted in our society very, very fast, right? And there would have been a multi-year shift. I think that's one big change that's happened. I think to the point around, another example of something that we've seen is we recently had the FDA, sort of accelerate us through to do remote monitoring or remote testing in an inpatient setting. So inside the people, inside clinics where COVID patients are being treated, to be able to use Livongo to test and maintain their blood sugar and blood glucose. And the idea again here is to reduce the face-to-face time that providers are spending or staff is spending with these patients, and subsequently also it helps things like PPE and other resources that may be scarce and potentially reduce the risk of exposure. So again, very fast change that have accelerated through the FDA. So that some of these changes are happening very fast.
Yeah.
And a similar one on telemedicine as well, which is, as we've heard, some of the government regulations around Medicare have accelerated, telemedicine access and some of the restrictions that previously, or the barriers that were previously required, so that more people can benefit from these digital platforms. So I think that's a shift where we were on that train, we were sort of in that direction, and it's just sort of accelerated a lot of our changes in our society in the last 6 weeks. And so that's one big area. And then I think with CGMs, which Dr. Gangupantula raised, I think again the use of CGM and that data is typically been sort of established for type 1 diabetes. I think for type 2, as you've heard already, I think we're still understanding the use cases and where do we benefit from this sort of higher granularity of data, this higher richness of data. Obviously, there are costs and other trade-offs of CGMs, and so I think those are also some of those changes will happen, and sort of maybe gradual shifts that we're seeing in our society.
Excellent. And we're getting a lot of questions. So I'm going to go through the questions. I'm going to jump to a couple of them that bubbled up as well. So thank you so much for sharing so far. So I'm going to skip over the other one because I think you addressed it a lot. But the next one is, first I want to start with you, Anmol, and then Dr. G, if you can follow up, is how are the digital health solutions such as mobile apps changing the tide in improving care and helping people with diabetes better manage their diabetes? And if you can give us a couple of examples. Anmol, I'll kick off with you first.
Yeah, sure. So I can go first, and I'll use some of the data we see from Livongo as an example, but also keen to learn from this group because I think we have some incredibly diverse perspectives, both on chat as well as on video. So, to self-management, I think as we all know, for about 32, 33 million people living with diabetes, there's a small number of endocrinologists, right? So I think there's about 8,000 endocrinologists for that large population. So clearly, supporting our healthcare system and our providers to really take advantage of technology, and particularly sort of self-management technology, is a huge opportunity for us. The example I often cite is sort of airline pilots, right? And so 200 years ago, a lot of things were being done where sailors were navigating, but today, if you see the job of an airline pilot, there's GPS systems, there's really sophisticated decision support tools and so on, and they're operating at a much higher level than sort of historically, right? So I think I think the role of a lot of these technologies, such as Livongo, is to enhance that support between visits to a doctor, which may only happen, I guess, 3 or 4 times a year for most people at most, right? So I think so that's the role of self-management technology. And so in our case, our focus is, again, as Dr. Cuttriss was highlighting, is bringing in the different sources of data, medications, coaching support, self-management, through digital coaching, through content, through exercises, to get people to make small changes that are in line with managing their condition, so that behavior change that happens in line with managing their condition. And so hopefully sort of that becomes a layer of support where this is then integrated into the care that they receive from their providers in those visits, and sort of is neatly sort of folded in and complementary and to the clinical outcomes that we're all trying to pursue for these members. Mm-hmm. That's kind of our approach to doing it, and I can go into more detail with that point.
Yeah. So moving to the providers, Dr. Cuttriss or Dr. G, I mean, you have Project Echo as a great example. I just want to turn the same question to you on the provider side of it.
Yeah. So I mean, I think going back to recommendations right now for like what improves outcomes. Going back to the initial studies, the DCCT trial, we know that frequent touch points, the more frequently you see a provider, the more opportunity you have to make change. And right now, the recommendation is to see a provider every 3 months. But when the studies were done, it was actually people coming weekly or every other week or monthly, and we know that's not practical. So how can we take the management out? Yes, I like seeing patients face to face, and the annual visit or so is important, but we need to empower patients to do this on their own the 99.995% of the time when they're not face to face with a healthcare provider. And so these apps and tools empower the patient to do that and not rely on me or anyone else on my diabetes team to be that bottleneck.
Yeah, and I wanted to add that the bigger chunk of nowadays, a bigger chunk in the population is the younger, the teenagers, the younger adults, and tech savvy middle-aged people who are actually taking advantage of these devices, these apps. And what I see is once they start using these apps, they are actually more interested and motivated in taking care of their diabetes. They are looking at the numbers and they are figuring out what made it go up and what they should eat less of, or what activity helped them to get their numbers under control. So definitely there is a good outcome that we will be seeing more of, and continuing to get better is with the use of these devices. There will be better self-management of diabetes.
And
interesting.
And maybe if I could just say one more thing, going back, before, now we're talking about CGM, but back early 80s, end of 70s, that's when we were just started home blood glucose finger sticks. And the dogma of the medical community was that patients can't do it on their own, right? They shouldn't do it, it's too painful, or they just don't know how to do it. So I'm seeing lots of that same type of dogma today regarding kind of apps and technology. And I think we have to really allow the patients to make that decision and not be judgmental based on their ethnicity, socioeconomic status, and not presume that people can't do this.
Yeah.
One of the questions, or main questions, I was just joining on a Medicare webinar previous to this, and they were asking, does age play into the use of technology, right? Also, for the older patients or younger, in your experience, probably Anmol, or for both the clinicians as well, do you see a difference? Because in that webinar, they said no, they actually use it more. So Anmol, have you seen anything?
Or you guys go ahead and I can chime in.
There, I do see a difference. What I would say is in my practice, I'm seeing like a 50-50%, because when a senior person has a family member to help them, they are able to transition into using these CGMs or apps more easily. If they don't have a younger person to help them, or any family member who is more into these apps or devices, then there's more difficulty, especially if they are living alone. They don't want to deal with it, because that's another thing they have to learn, and it is very overwhelming. They're already taking care of their diabetes all by themselves, and now the doctor is introducing them to these devices. So what I offer from my team to my patients is I offer them telephone support any time of the day or night. And sometimes I have patients calling me just the other day, 12:40 in the morning, 1:20. They're just calling and saying, my sensor shows it is low. What should I do now? So I walk through the next steps with them, and it turns out that just double checking with the finger stick helps them to reduce their anxiety. And one of the senior patients who called me couldn't find her blood sugar monitor. So I had to just sit and talk on the phone a little bit until she was able to find it, and it all got better. So I think for the senior folks, it is very challenging, but if we find some ways to support them, we can help them through this.
Yeah, thank you.
I don't know if you want to add more, Dr. Cuttriss, but I can go in. And so I think, so just saying in our data, we actually see higher blood glucose checking for the 65 plus population than overall population. And, we're still trying to understand what's driving that. And I think Dr. G had some good ideas for maybe they're supported by a family member or so on. So I think it's worth figuring it out. But certainly we see a pretty high level of engagement across the board. And then the other thing that's been important for us in that population especially is this idea of personalized support, right? And so if you sort of distill what you're saying about someone out there is kind of helping you figure out what you need to do as an individual, that could be a family member, or that could be a series of algorithms that are helping figure out how do we support you, right? And so that level of personalized support within the 65% and 65 plus populations, also we're seeing is driving a lot of is driving people towards better outcomes and higher engagement and just better self-management of their condition.
And just to point out too, Medicare CGM is approved, but Medicaid, which differs per state, is not. And so it's more available, across state lines. And we refer to this as diabetes technology and devices, but I think using the word technology to some people might be a little intimidating. This is really just diabetes management, right? If someone's getting a heart monitor placed in, we don't call it technology. We call it saving your life. This is a treatment. So I think with diabetes, we need to start moving in that direction. And yes, underlying there is technology involved, but this is just management, and there's many different options for them. And yeah, technology is involved.
And that's a great point, because the best technology is the one where you don't know it exists, right? It's so intuitive and it's so baked into your day-to-day life, and it's giving you sort of the most relevant insights and the most relevant perspectives that you don't have to think about it as a technology or something different.
I just want to add something with the older folks. Even 3 years ago, when Medicare approved the CGM, it was a little difficult. You had to go through, as a provider, you had to go through a few steps to get that device for the patient. And when we got it, a few of my older folks actually came back and returned it because they were so they felt very overwhelmed. What I did recently is, in the past 3-4 months, I have taken, consent from an older person who is already using it to help the other person understand. I have like a group that I have support groups that I meet with them once a month. So when I introduce them to each other, then they have supported each other, and a few patients are now motivated to start using it. So that could be another idea that some people can use.
Yeah.
Excellent. Thank you. So I'm going to go to the next question, and this is for each of you, whoever wants to take it first. It's kind of going back to what we explained, but then just to go a little bit deeper would be device data from glucose monitors and smartphones can be used to share nuggets of information, alerts to the person with diabetes. And do you think that the people with diabetes managing this can effectively self-monitor based on these solutions? And do you foresee the need for care coordination team to perform interventions?
So, yes to all the above.
Yes, it is yes to it. It's yes to all of what you said, and it is actually very helpful to these patients, even if they are older. And now we talked a lot about the 65 plus population. I wanted to talk about a little bit about the teenagers that I have in my practice, and the young adults, especially if it's a young mom with 2 or 3 kids under 5. She's so overwhelmed with taking care of the kids. She's not having time. They don't find time to even check their blood sugars. That will be a very good device for her or her family members to help her with. Then there are teenagers who feel that, and I saw on one of the comments on the chat, and I completely agree with that. The teenagers do feel that it makes them stand out if they wear something, and they're refusing to wear the CGM or even go for the pump. So that population, it is a little bit hard to convince or get them to use the devices, either because they're overwhelmed with what they have going on in the family, or just to be cool among their friends. So we need to figure out some ways to help them. And what I do is, if I have other teenagers who are using it, I connect them with each other in my support group, and it has helped the other teenagers who are not using it, or the young adults who are not using it, at least to start thinking about it. And what Dr. Cuttriss said, Medicare has approved it, but the Medi-Cal has not yet approved, and I'm not sure in the other states if the state insurances are approving it, because I feel that is a population that does need a lot more help than the other populations.
Yeah. Yeah, I mean, I would add. So I think one thing that I've learned in my experiences in the space is there's a lot of technology we can build for self-management, and Livongo certainly we've invested heavily in sensing and personalization of care and health nudges to guide people. But all of that sort of hinges on a couple of points when it comes to working with our existing health system. So one is our providers and our health systems have to be able to really trust these technologies, right? So for our product, clinical validation is really important for a provider who's offering our product to their population, and knowing that here their clinical outcomes is about 34 academic articles and abstracts that point to everything that we're doing, and even do for features we're building in the mobile app, right? So we recently had a behavior change feature that was 5-day programs that was targeted helping people with certain skills. But we came back and we 6 months later kind of published and said, hey, here's how well this works, right? In a peer-reviewed venue. And I think that mindset is really important for providers and provider systems to be able to trust these remote monitoring technologies, because there's a lot of sensors, there's a lot of apps out there, but which ones do you really believe have the rigor and the clinical validation? Because we're dealing with people's lives at the end of the day, right? So I think that's really important. So that's one. And then the second is kind of for the remote monitoring and self-management approach to work really well, having intuitive and seamless integration with the provider's workflow is also important. And in our case, we have health summary reports, which is essentially this easily digestible sort of summary of a person who is on Livongo that a person can, with a click of a button in the app, send that information over to or on the meter, send that information over to their provider's office, right, or to their provider. And they could do this right before they come in, or they could do this during the session, or they could do this on a regular cadence where maybe they're connecting on telemedicine or they're connecting electronically, and the provider's kind of getting updates. And so that balance for us was really important, because we don't want to overwhelm the providers with a ton of data, right? It doesn't make sense for us to send each and every sort of data point, but we also want to make sure that the support members getting from our platform is neatly integrated with the path that the provider has in mind, and those two, and they have access to the summary and the insights that they can sort of empower them to sort of really be, having those two sort of work in lockstep and in sync. So I think those two, so clinical validation rigor, where there's thousands of apps in the app store, which ones do you really trust and have that rigor behind them? And the second one is, really thinking about how you summarize the information that providers can really take advantage of that. Both of those are really important.
And as we move into this era of personalized medicine, these devices are allow the user to set alarms when they want to get notified, and that's really important. Of the various CGM devices out there, some are more annoying to patients than others, and so you kind of and the technology continues to get better, so people can trust it. With the alarms, especially teenagers, they don't want to be alarmed when blood sugar is over 200, because for the most part it always is on the average. And then I think then there's this kind of thing that, in the U.S. in terms of teenagers is very different than other underserved countries where I work, where a teenager would be so grateful to get on any of these wearable devices. So I just also think there's just a mentality or culture within the U.S. of, it's great we have choice, but we spoil our kids, and there's kind of too much choice sometimes, where it's just, like I was saying before, this is kind of matter of fact, this is part of diabetes management, right? Okay, which one are you going to use? But it's not, okay, you're not going to use any of them. But right now, that's where we are, and hopefully over time we can continue to incorporate that. And then if you aren't aware, there's a great website, diabeteswise.org, that is, it kind of allows patients to figure out which device is best for them. And so hopefully we'll continue to go towards that trend.
Excellent. What I'm going to do is I'm going to go to the polls right now. We had a poll question asked early on, and we have a second one. So just to make sure everyone's not multitasking out there to answer the second one. But the first one that was asked was kind of easy one, was do you think COVID-19 highlights the need for remote patient monitoring for people living with diabetes? And all the votes agreed. And Keith had a question in the chat similar to that. And I want to open up to the panelists here is, can you explain more on remote monitoring or telehealth that we mentioned. So I think everyone agrees there. If we can explain a little bit deeper on what RPM is and telehealth.
I think Dr. Cuttriss will be a better.
Unfortunately, there's no kind of universal definition of what telemedicine, all these kind of different types of tele, right? And so in terms of remote monitoring, as you think of kind of disease management, and the kind of old way was maybe writing logs down or plugging your device and kind of quote, downloading, printing out data. And now it's more of uploading data that goes to the cloud, and the provider can, not just the provider and the care team, but the person living with diabetes is able to access that data, interpret it, and make changes. And so I think now in terms of the time of COVID, of this remote monitoring of the payer enabling the medical practice to be able to bill and get reimbursed for some of these services. I think it's going to be difficult to go back now once we've come to COVID. I think patients are going to speak up and not allow to go back to these old times.
So I'll just add a little bit of what I'm doing in my practice. With my population, many of them don't have computers or the ability to send me an email or plug into the device at their end so that we can monitor it. So all these past few weeks, what I've been doing is having my MA call them ahead of time and get their numbers and write them down. So most of my patients are actually comfortable doing that than going through the step-by-step instructions from my MA to plug it into this computer or that port. It's hard for them to follow that. So the monitoring that I'm doing is by just getting their numbers written down, and then the MA brings it to me. When I make the telehealth call, I go through the numbers with the patients. And what I ask them to highlight main things are, give me what was your highest number, and we'll talk about why it went that high, and what was your lowest and how many times you had the hypoglycemia. So that has helped my patients with the remote monitoring in that sense.
Yep. And Anmol, how does the Livongo program enable RPM and allow someone like Dr. G to work at the top of her license? Would you say?
Yeah, no, that's exactly right. And so as Dr. G is describing, right, and so what we've done is essentially platformize a lot of what is happening with DMA in that example, right? And so and it starts with giving people the devices and the support they need, providing them with unlimited strips in the case of BGMs. Obviously with CGM, it's a little bit different. We have partnerships with the leading CGM companies like Dexcom, so that allows us to bring that data in, integrate the data sources from other areas. So we heard about medications earlier, and so trying to figure out, hey, who is likely not be adhering to their medications? Social determinants such as food insecurity is a really important variable as well, and often just looking at demographic information and so on can give you a general sense of where people are. So bringing all of those insights and then saying, here's the best way to support this person. Here's where we can make it easy for them to make the decisions that they need. We can personalize their experience. We can drive the behavior change that we're driving, in particular in type 2, where a lot of it is sort of lifestyle and behavior management, right? Behavior change. And so I think those are some of the steps that we take. And on the tele and remote side, we have real world data. So the blood glucose meters, the blood pressure meters for our hypertension product, the DPP product that we have as weight scale. So they're all cellular connected. So they have a two-way connection. So the person doesn't have to pair anything to a laptop. They don't have to get the Bluetooth connector going. It's all sort of built in. You turn it on, and then there's a two-way connection with just the device and our systems. And then on the telemedicine is figuring out how do we support these people with coaches, with clinicians through our telemedicine, across different areas. So it could be, even through our telemedicine partnerships. where most of that is happening through a digital format, so it's either video or it's text-based. And particularly, some of the areas where we've been able to use, as you heard, so my background is in machine learning, and some of the areas we've been able to use machine learning is actually figuring out, who's going to benefit from talking to a coach, connecting to them early, making sure that's part of their care experience, making sure the coaches have all the relevant data on what should we talk to this person about, what are they receptive to, what are their needs. And so it's about taking those things that are happening at an individual provider level, as Dr. G described, where the MA is kind of doing that, but then baking all of that intelligence into the actual platform so we can support, and so the same provider can sort of support a much larger group of people, and the systems can kind of help scale how our providers operate. And so the phrase that we often use, as Vu said, is helping providers practice at the top of their license, right? And that's the example I was giving earlier with the airline pilots, right? And so like having the systems kind of help them, give them the support they need to really focus on the place where they can have the most value and the most sort of strategic perspective and insight.
And I think it's important to add in terms of the top of the license, it's not just specialists, because as we mentioned earlier, there's not enough specialists to care for people with diabetes. So the primary care providers, nurse practitioners, that's probably saying that majority of people with diabetes and majority of people with diabetes aren't meeting targets. So do we have an opportunity now to incorporate remote monitoring into quality improvement practices in the primary care setting as well?
And I think that's really important, and it also extends to behavioral health, right? And as we've all seen in the last 6 weeks, and with part of supporting people living with diabetes is also supporting stress, anxiety, and other things that are now even more sort of important, and given the circumstances we're in, where people may have lost their jobs, they may have lost their loved ones, and maybe going through a lot of just balancing having kids at home, which they don't have that separation from work and home anymore. And so I think within that, part of our approach has been identifying people who will benefit from behavioral health support, and then connecting them to our My Strength resources. And actually we've seen a pretty significant uptake in just the last 6 weeks, and people taking advantage of that benefit across our 1,200 or so clients, across our entire client base. And so that's been a pretty promising. And again, this is where technology and algorithms can help scale the process. An individual provider will make that decision too, but again, it's like we can now do that over hundreds of thousands of people or millions of people programmatically, much more scalably, and so kind of like support the providers in a lot of that early identification and escalation.
I want to make a quick comment about the health coach that both Anmol and Dr. Cuttriss have mentioned. Being part of Dr. Cuttriss's ECHO program has actually helped me to have a health coach for my patients, and I agree completely that having a health coach to help them through their difficulties or challenges is enabling my patients to take better care of themselves. So that's a good point that Livongo is helping, and ECHO is helping.
Yeah, excellent. So last question before we go into the chat for questions. We're coming up on the 10-minute mark. So final question, Dr. Cuttriss, if you can kick us off on this last one. We talked about this when we synced up, is delivery of care of telehealth in the times of COVID-19, moving forward to make it easier and efficient patient care versus 3 months traditional model. And what's driving it? Is it reimbursement or is it COVID-19?
Yeah. So right now, as Dr. G mentioned, she's able to pick up a phone call, pick up the phone, check in with someone, and actually bill for her time. The traditional model doesn't pay providers on performance. It pays providers on seeing patients, whether you have terrible outcomes or great outcomes. I think hopefully this will also push more for pay for performance and working towards quality care, quality improvement. But now hopefully, and going back to the studies I mentioned earlier, we know that frequent touch points weekly, every 2 weeks, works. And how we got to every 3 months, I have no idea. And so hopefully now providers can start to get reimbursed for, and not just providers, but the team. So we're the social workers, the nurses, everyone in the clinic that helps out with the complexity of diabetes that goes beyond just kind of adjusting medications and products such as Livongo and many others out there on the market. How can that kind of also be paid for and utilized?
Excellent. All right, I believe that we captured all the questions, and if there's any new ones, please have them come in. We have about 5 more minutes before we close out, and I've asked the panelists if we go through all the questions, which we did, is to kind of ask one another what projects you're working on, any challenges you're having, and kind of bounce ideas off one another. So Dr. G, if you can kick it off, and then, or if there's anything else you'd like to do a deeper dive, please do.
I wanted to add one more thing before
Sure.
we do the last activity. I believe that not just patients with diabetes or pre-diabetes, but even healthy patients who are motivated, or patients with impaired fasting glucose should have access to these devices and not have to pay for it, because I believe that if a patient is motivated, if a person is motivated to prevent diabetes, they should be allowed to have that access for continuous glucose monitoring, because that will completely change their the way they'll start changing their lifestyle and behaviors. So I believe that it should be extended even to, right now, pre-diabetic patients with pre-diabetes are not allowed. I mean, they don't have that access through their insurance, and I feel that they should get it too.
Yeah.
Yeah, I mean, I'd say I have a couple of points. So on the pre-diabetes, I think, certainly we have a program in pre-diabetes, and so there's a number of sensors and support mechanisms with the same principles, maybe slightly different sensors that can help people manage, in diabetes prevention programs or pre-diabetes weight management populations. So certainly a lot of that is happening, and we can add more context on that in more detail offline. So that was one. And then the other point I wanted, we spent a lot of time talking about this from the member perspective or the patient perspective, but I think it's equally important, just given this audience, to talk about it from the provider perspective, right? So when I think of this, the value of these technologies, it is, one of the things we haven't touched is helping providers sort of, manage their workload, sort of, and frankly, reducing provider burnout. And is a provider finding value with this tool? And again, different layers of the medical stack, right? So certainly endocrinologists, and then primary care, and then nurse practitioners and coaches. So I mean, all different layers of the stack. Is everyone there kind of saying, hey, this technology makes my life easier, right? And is this actually making my time more productive? Am I able to find that work-life balance that I'm seeking? Am I able to support the same number of patients or even larger, use it with the help of these technologies? And so I think success in my perspective, for products like Livongo, certainly for our vision, is that we have to also hit that bar, right? And call it a provider NPS for the lack of a better metric, it really matters, right? It isn't just about the patient member, because I think getting both of those moving in the right direction will have a huge impact on how we scale our access to care in our healthcare system. And so that's one point I want to sort of reinforce, given this particular business audience.
Excellent. All right, I'm going to ask a couple of the questions here. We have one from Jason. He asked, are you more comfortable titrating patients on insulin to goal with improved RPM?
Yeah, absolutely. And then also there's another question there in terms of the role of the diabetes educator and pharmacist with RPM in the future. And so, diabetes specialists, endocrinologists, we should not be the gatekeeper to allowing patients to titrate doses. I mean, they do it on their own. They make the decision every day. So really, they can do it. And so empowering them to do it, but there can be other people, other workforce who make those decisions, and it doesn't need to be the endocrinologist or specialist. And maybe there's some things that we're involved in terms of the care. But once again, we really need to democratize this decision-making process and when the patients can make that decision, they have more information with the remote monitoring. That's fantastic.
Yes, and I actually part of my education during the patient visits is to teach them and educate them how, and make them more comfortable on titrating their doses. And that's what I feel is very important, to empower them so that they don't have that fear of insulin.
Excellent. All right, one final question, and then we're going to have to try to figure out how to answer the rest because there's quite a bit of questions here. This one got voted up quite a bit. And final one is, given health systems have been increasing their focus on patient engagement to improve chronic conditions for a few years now, do you see patients being more receptive to using app-based interventions like a Livongo or Noom or even diet fitness apps in the current climate, or are SMS-based interventions preferable? And are they ready to invest in them?
I'll jump in. I think yes. But I think in addition to direct-to-consumer, we also have to partner with the clinics and the providers and educate them about these so they can recommend it to their patients as well, and kind of have a top-down and bottom-up approach at the same time.
Yeah, thank you. All right, so I want to stick to time. Thank you, everyone, for joining. I'm going to speak with Jason at HIMSS to see how we can address these other questions because there's quite a bit. But thank you, Anmol, Dr. Cuttriss, Dr. G. Great discussion. I hope everyone who took the time to join us, hope you gained something from this and really appreciate it. We're going to be on a break for next week, but then we're going to come back with another session on remote security for remote patient monitoring in 2 weeks. So please do join us for that. Thank you, Livongo, for sponsoring, and thanks for joining, everyone. You'll get a recording of this.
Thank you.
Okay.
Thank you.
Take care, everyone.
Bye now.
Thank you.